Okay, so the special senses will focus on the eye and ear. I would focus on those more than anything else in that exercise. So with the eye, you should know the 6 extrinsic muscles, means muscles outside the eye. The intrinsic muscle refers to the ciliary body and iris. But the extrinsic outside the eye muscles are the 4 rectus muscles, superior, inferior, medial, and lateral rectus, the superior oblique, and the inferior oblique muscles. So those 6 move the eye up, down, left, right, and can rotate the eye to some degree as well. So a possible extra credit will be the cranial nerves that control the 6 extrinsic eye muscles. If you remember from last semester, there are a total of 4 cranial nerves that go to the eye. The optic nerve is the one that's not seen here, obviously bringing in visual information from the retina. But you have the trochlear nerve that controls the superior oblique muscle. If you remember, the superior oblique passes through that little hook-like structure that you see called the trochlea that allows that muscle to change the direction of its pull. The abducens nerve, which abducts the eye, pulls the eye away from the midline, which is your lateral rectus muscle, and the other 4 are controlled by the oculomotor nerve. So again, possible extra credit would be know those nerves there. So you should know the layers of the eye. The outermost layer is the fibrous tunic. The next layer in is the vascular tunic, and the innermost layer is the nervous tunic, sometimes called the inner tunic. Classically, they're the fibrous, vascular, and nervous tunics. The fibrous tunic is the sclera, the white of the eye, most posteriorly. Anteriorly, these fibrous tunic is made up of the cornea. So the cornea and the sclera make up the fibrous tunic. The vascular tunic consists of the choroid, which is the very vascular layer between the sclera and the retina. Posteriorly and anteriorly, the vascular tunic is made up of the ciliary body and the iris. Again, the ciliary body controlling the shape of the lens and focusing, and the iris changing the size of the pupil to regulate the amount of incoming light into the eye. You don't see here on this label, but you should know the oris aorta as well. And again, don't concern yourself so much with the chambers, where you see the anterior chamber, posterior chamber filled with aqueous humor, and then the vitreous chamber posterior to the lens filled with vitreous humor. You will see that slightly different and different terminology in different textbooks. So just be aware of that. And again, you should know that the pupil is the whole. The iris is the diaphragm that regulates the size of the pupil. So again, a possible extra credit is labeled on this diagram. You often see it shown on the diagrams of the eye but not labeled, and that is the hyaloid canal, a little canal through the vitreous chamber, basically running straight from the optic disc to the posterior of the lens. And again, the optic disc is your blind spot where the optic nerve and the artery and vein of the retina enter the eye. There are no receptors in that area. You cannot have 2 things in the same place. So there are no receptors in your blind spot. Your brain fills that spot in, but you can test for it. And again, when you're looking at a superior view of the eye, remember the optic nerve will always travel medially. The 2 optic nerves meet in the midline at the optic chiasm. So the optic nerve is going to go medial on the retina, and the fovea centralis and macula lutea will be more lateral. Again, macula lutea, literally yellow spot, is a visible spot when you look into the retina. The fovea centralis is a small pit in the middle of that spot, and again, the fovea centralis is that area of greatest visual acuity, very highly packed with cone cells that are the color detecting cells we use all the time. And when you are looking at something, that image of whatever it is you're focused on, that is projected onto the fovea centralis. That is our center of our field of view. Everything else outside of your central focus is projected onto the rest of the retina. Again, here you see the ora serrata labeled, literally the serrated mouth. That is the anterior edge of the retina, but the ora serrata really is part of the ciliary body, ciliary muscle that connects to the lens through the suspensory ligaments and changes the size of the lens. Again, vitreous humor is more gel-like, and aqueous humor is more liquidy. But if you imagine the vitreous humor as jello and the aqueous humor as the water that's trapped in that jello, there is a small amount of flow that happens through that liquid within the vitreous humor, as well as the aqueous humor itself flows from the ciliary processes where they're made. Basically, it is a blood filtrate, sometimes referred to as an exudate, but just like urine, many other fluids through the body, they are filtrates of blood. That aqueous humor is then reabsorbed through the scleral venous sinus, and again, this process of certain things, a certain thing being produced at a rate and also being reuptaken at a certain rate, those rates have to equal each other, otherwise you will get buildup of pressure. Again, the basis behind glaucoma is the scleral venous sinuses do not reabsorb the aqueous humor quite as fast as it's being produced by the ciliary body, and pressure will build up. Again, enough pressure will push against the retina and damage both the nervous tissue and eventually cut off blood supply as well, and starve the tissues that will basically served by the retinal artery. So again, the ciliary body, I don't care if you refer to it as the muscle ring, the whole thing together, the ciliary body regulates the shape of the lens. It is attached to the lens through these many small suspensory ligaments around the periphery of the lens. And again, remember, there is natural tension due to the liquid within the eye, the aqueous humor, that actually pushes the eye out in a way, pushes on the fibrous tunic, on the sclera from the inside. So there is naturally tension on those suspensory ligaments. So the natural state of the lens is for there to be tension on the suspensory ligaments and the lens to be relatively thin on the anterior posterior axis. And again, that is a state of focusing on something far away. And again, when we need to focus on something near, the ciliary body actually contracts, and again, because it's a ring, when it contracts, the diameter of the inside of that ring decreases, so that the contraction of the ciliary body actually alleviates the natural tension put on the suspensory ligaments by the fluid within the eye, and that allows the lens to thicken anterior to posteriorly. So the lens will get thicker, and again, that thickening of the lens is referred to as accommodation, and that allows for focus on something closer as opposed to something far away. Again, regulating light, you have the pupil. The two muscles of the pupil are the sphincter pupillae, which, as it sounds, it's a sphincter. When it contracts, it reduces the diameter of the pupil, and the dilator pupillae. And if you look at the orientation of those fibers, the sphincter pupillae, those fibers are oriented circumferentially around the circle, and the dilator pupillae, those fibers are oriented radially, so that when those fibers contract, they actually open the hole and increase the size of the pupil. I didn't put it on this slide, but again, a possible extra credit is knowing which of these is innervated by the parasympathetic fibers and which is innervated by sympathetic fibers, which is your at rest versus your fight or flight. So when officers of the law are looking to see if you're under the influence of a narcotic of some sort, they will often shine a light in your eye and see if your pupils constrict in response to that light like they're supposed to, or if they stay dilated because you are under the influence of your sympathetic nervous system. So again, something else to kind of think about. Might be extra credit. So this view shows what your optometrists would see as they're looking into your retina. Usually they will dilate your pupils for this. Again, the optic disc is where all the blood vessels seem to originate from, and the little yellow spot just to the left of that is the macula lutea, and again the fovea centralis. Fovea centralis really is not visible in this aspect, but it is, if you look at it microscopically, it is a smaller pit within that macula lutea. So again, you should know the conditions of the eye for distant vision versus near vision. So distant vision, ciliary muscles are relaxed, tension in the suspensory ligaments is high. Again, this is the normal state of the eye, and that causes the lens to flatten front to back. Okay, so that is your distant vision, what's usually referred to as emmetropia, looking at something far away. Okay, so near vision, again, the changes that occur, you have your ciliary muscle contracting, what actually alleviates the tension on the suspensory ligaments, so that it reduces the tension on the suspensory ligaments and allows the lens to thicken under its own power on this anterior to posterior axis, front to back. Now, how much that lens thickens will depend on the age of that lens, and the older a lens gets, the less it thickens and rebounds. Okay, so again, accommodation is the thickening of the lens, and the ability to accommodate diminishes with age. Now, the nearest that you can focus on something is what's often referred to as the near point, or sometimes the near point accommodation, and that is what actually reduces as you get older, your ability to focus on something close. So accommodation specifically refers to the lens. The near point is the distance at where you can read something. So again, same thing we just talked about, different textbooks, different visuals of the eye. So you have distant vision, again, emmetropia, relaxed ciliary muscle, suspensory ligament tension is high, lens is pulled tightly around its periphery to make it thin front to back. And when you focus on something nearby, you have what's referred to as accommodation. So again, accommodation is the thickening of that lens when you contract your ciliary muscle and reduce that tension on the suspensory ligaments. So that allows you to focus the image of something nearby on the retina. So some of the changes that occur, we've already talked about one. One should be hopefully kind of self-evident. I know, like little kids games where they play with convergence. Follow your finger or follow your friend's finger with your eyes, and they play with it, get close to your eyes and make sure your eyes converge. Those of you who can cross your eyes, obviously that's convergence. So the changes that occur when you go from looking at something very far away to something within a few feet are, one, convergence of the eyes, where the eyes themselves are focusing more medially. Constriction of the pupil that allows for a more sharper focus, and you also have thickening of the lens, which is accommodation, so that allows to focus on something closer as opposed to something far away. So for correcting sight, now I will mention before we talk about this, I think I mentioned in some of the lectures, I have a little problem with this diagram. Technically, it's not quite accurate. If you look at the emmetropia eye under part A on the left, it says the focal plane is on the retina. Yes, that's correct. But where the light rays all come together, they don't quite come together on the focal plane. They come together before they reach the focal plane, converge, and then spread back out again, and actually project an inverted image. Okay, so this is not quite correct. If you, in reality, where all the light rays come together at one point, all you would see is a very bright dot. Okay, so it's actually past that a little bit. I get what they're projecting here, but I just want to make that clear that this, it technically is a little bit incorrect. But if you look at the conditions, hyperopia, which not many, I feel like more people are myopic, but hyperopia is farsightedness, where either your eye is too short or the lens and the cornea are misshapen, and you end up projecting the image behind the retina, and you correct that with a convex lens that focuses the image a little bit more. It actually, a convex lens helps to focus the image before it's focused by the cornea and the lens. So it is a convex lens is a focusing lens. If you've ever played with a microscope and ants or something like that in the sunlight, a convex lens is a focusing lens. It focuses that beam. So if someone is myopic, their image is actually projected a little bit anterior to the eye. Either the eye is a little long, or the lens and cornea just are misshapen enough. And for correcting myopia, you actually have a concave lens that actually spreads those rays out a little bit before they reach the eye, because a myopic eye actually focuses the rays too much. So you spread those rays back out to let them be refocused again by the myopic eye. And again, the poor sap that's got the myopia usually has the thick edged glasses, because look at the shape there. That's concave. It has a very thick edge, as opposed to the convex lens. Again, this slide I didn't mention much during lecture, but it's just kind of showing one, that the eyes converge on a nearby object, and two, if you just look at each eye individually and look at the different colored bands, now this does show how light rays will come into the eye, converge at one point, and then spread out, and basically an inverted image. Left is right and up is down, and vice versa. So again, if you're trying that blind spot determination little piece of paper with the X and the dot, you're going to close one eye, and you're going to, whichever of those two, the X or the dot, whichever those two is medial, you're going to focus on that with the remaining eye. And again, if you look at the red line, if you focus on something medial, that gets inverted and actually strikes the retina kind of laterally, and that will fall on your fovea centralis, what you are looking at. And something that is more lateral, like the blue line, will actually project it more medially, and will eventually, as you bring it close enough to your eye, will strike across the optic disc and fall on your blind spot. So that's why when you're doing that blind spot trick, regardless of the eye that is closed, the eye remaining open, you focus on the object of interest that is more medial, and the blind spot will appear more laterally. So looking at the ear, you should know outer versus middle versus inner. The outer ear basically ends at your tympanic membrane. The middle ear is an air-filled chamber between the tympanic membrane and the inner ear that contains the three auditory ossicles, malleus, incus, and stapes, as well as a couple of muscles, tensor tympani and stapedius. There's a nerve that runs through there as well that we didn't really mention. But you should know as well the auditory tube, eustachian tube, and I know there's other terms for it. I think somewhere I've seen like otopharyngeal tube or something like that, but you should know that tube as well that connects to the posterior oropharynx and allows you to equalize pressure whether you're flying in a plane or scuba diving, preventing you from rupturing your tympanic membrane. Again, that is an air-filled cavity, so you need to keep that pressure equalized. The inner ear is a fluid-filled structure that kind of looks like a snail with three big loop-like antennas on its head, I guess. The snail-like structure, the spiral, is the cochlea that picks up sound waves, and that information is conducted through the cochlear nerve. The three semicircular canals, as well as the vestibule, the kind of the middle region would be the vestibule, serve the vestibular nerve and conduct balance and equilibrium information to the brain as well. The vestibular nerve and cochlear nerve very quickly merge through the same neurolemma type sheath and are known as the vestibular cochlear nerve. So you should know the structures that you see here as well. So the acoustic reflex tries to prevent damage to the cells of the inner ear by dampening vibrations as they travel through the auditory ossicles. You have two muscles. One's the stapedius that connects to the stapes, and the tensor tympani muscle, which connects to the malleus. The acoustic reflex is think more rock concert type of noise that is increases in volume gradually. There is a limit, though, of about 20 minutes for this reflex. Anything longer than that, you will start to receive hearing damage. And it is a slow reflex. If you shoot a gun without hearing protection on the first shot, you will probably have a ringing sensation because that reflex was not activated. That reflex would then be activated, and on subsequent shots you would notice a difference in the sound of the shot. But it is a relatively slow acting reflex that again does have a time limit. So you should know those two muscles, tensor tympani and stapedius. So taking a closer look at the cochlea, if you make a section through one of the turns, you will see three different fluid-filled chambers. The scala vestibuli, or scala vestibuli, again, tomato, you hear a lot of these pronunciations. And the scala tympani, both contain what's known as perilymph. The cochlear duct, or sometimes referred to as the scala media, contains what's known as endolymph. These fluids are very similar as far as how they respond to vibrations, but they are different in ionic concentrations, so they are different and are kept separated. Again, this is on other slides, but you should know that the path of vibration starts in the inner ear from the oval window. Remember, the foot of the stapes sits on the oval window. As the foot of the stape vibrates, it moves fluid through the scala vestibuli. So the vibrations travel up the spiral through the scala vestibuli to the helicotrema, the tip, where they do a 180-degree turn and come back through the scala tympani. And where the vibrations leave the inner ear is through the round window, which is not shown on this diagram, but the round window exits back into the middle ear, back into air, where the vibrations dissipate. Again, as vibrations travel through the scala vestibuli up to the helicotrema, they will also travel through the cochlear duct, through the vestibular membrane, into the cochlear duct, and past the spiral organ, and back into the scala tympani. We'll look at the basilar membrane. If you look close at the spiral organ, you have three outer hair cells, or three rows, sorry, technically, of outer hair cells, one row of inner hair cells, and they are basically attached to the tectorial membrane above and to the basilar membrane below. The basilar membrane is the important one. That is the one that changes length as you go from the base of the cochlea close to the oval window up to the apex of the helicotrema. That's going to be an important one with regards to where along that cochlea different frequencies of vibration, different frequencies of sound are interpreted. So just another view of the inner ear, showing a section through the cochlea. Again, you have the scala vestibuli that takes the vibrations from the oval window up to the helicotrema. The scala tympani brings the vibrations back from the tip of the helicotrema out to the round window. The cochlear duct, or scala media, is where the spiral organ is located. Again, the spiral organ basically consists of these four rows of hair cells and some supporting cells. The inner row of the inner hair cells, that single row, is what actually has the afferent nerve fibers that go to the brain, and it is these that interpret the different frequencies of sounds, the different pitch of sounds. The outer hair cells, the row of three, these have basically efferent fibers that allow them to kind of respond to the brain in a way to fine tune where along this basilar membrane certain frequencies are interpreted by the inner hair cells. So there's a couple of methods of kind of fine tuning the interpretation of frequencies. One is through the outer hair cells and their change in tension between the tectorial membrane and the basilar membrane. Again, those hair cells we'll look closely at in the next few slides later on. But again, they have the stereocilia tips embedded within a tectorial membrane, and the base of them, is the hair cell, actually sits on the basilar membrane. So again, just read through this if you've unroll a cochlea. This is kind of what you have basically, but if you read through this, this will again show you the pathway of sound as it travels through the inner ear. That's definitely something you should know for the practical. So again, the diagram A above is a cochlea that has been straightened out. You can see the scala vestibuli above, scala tympani below, cochlear duct in between the two. And again, the foot of the stapes sits against the scala vestibuli, and the scala tympani opens up at the round window. And again, the basilar membrane, different parts of the basilar membrane respond to different frequencies. The parts of the basilar membrane, the more proximal end, closest to the foot of the stapes, responds to higher frequency sounds, and lower frequency sounds are interpreted at the distal end of the basilar membrane, closer to the helicotrema. That's where you get you pick up your low frequency sound. So again, I know I mentioned this in lecture, but if you're going to have hearing damage, it is most likely going to be in the high frequency range, because that those cells right there that pick up that high frequency sound are right next to the, they're closest to the foot of the stapes. And if you have a very large amplitude sound, a very loud sound, that foot of the stapes is moving very rapidly and very it's moving a greater distance, and it's with more force. So those cells will be damaged. So you'll have high frequency sound loss before you'll have low frequency sound loss. So again, another kind of diagram of the basilar membrane. So again, the tip near the base near the oval window is where you have the high frequency sounds, 20,000 hertz. And again, you should know hertz. That is basically cycles per second. So you have 20,000 peaks, wavelength peaks that come by, per second, as opposed to 200 hertz, a very low frequency sound where you only have 200 of those peaks per second. So again, if you straighten that basilar membrane out and actually look at it closely, it is more narrow towards the oval window and is wider towards the helicotrema. And if you look at that, that should remind you of anything from a pan flute to strings on a piano to any type of sound where you've got or even strings on a guitar. You've got a short string that gives a high frequency sound, and you've got a longer string that gives a lower frequency sound. So you think of resonation. When you have a low frequency sound, it will resonate with those longer fibers in the basilar membrane that are closer to the apex of the helicotrema, or the helicotrema of the cochlea. So this is a basic concept map of how the inner ear works. So vibrating air reaches the tympanic membrane, causing the auditory ossicles to move, which transmit that vibration through the ossicles to the foot of the stapes. So this transmits the vibration from air to a liquid. And if you notice, the size of the tympanic membrane is much larger than the size of the foot of the stapes. There's a lot more we could go into with that, but just suffice that it takes a lot more energy to cause fluid to move than it causes air to move. So you need a bigger footprint on the air side to transmit that energy through to the liquid side. So the liquid, the perilymph within the scala vestibuli starts to vibrate. Again, those vibrations travel up through the scala vestibuli to the helicotrema, back through to the round window through the scala tympani, and as those vibrations do, they will travel through the basilar membrane, and again they will kind of harmonize with certain regions of that basilar membrane depending on the width of that basilar membrane. So the region along the basilar membrane that is stimulated will tell our brain what pitch we are hearing. Again, the vibrating fluid travels out to the round window where those vibrations are allowed to escape through the round window into air, the air of the middle ear. So you should know the basic concept behind stereocilia. It is a series of little cilia with on the membrane of a cell that get taller and taller and taller towards one side. The tallest cilia has a tip that is embedded either within the tectorial membrane or with an otolithic membrane if we're talking about the balance mechanisms within an ear. But basically, the tips are connected by a little link that is attached to a mechanically gated potassium channel. Potassium, just like sodium, if you open the channel, it allows to flow in the cell and will change the polarity of the cell. So this is again, this diagram is illustrating a point, but the total point is also that the cells or the cilia can bend the other way as well. So if all the cilia bend to one way, all the gates will open, and that cell will become depolarized. If all the cilia are standing straight up, maybe half the gates are open, half the gates are closed. It's kind of a neutral position, but it's still polarized to some degree. And if stereocilia all bend the other direction, the opposite direction, then they will become hyperpolarized. So basically, the hair cell can determine whether the cilia are bending to the left or to the right. So it doesn't just determine whether they bend, it can also determine directionality as well. And this can help us determine up from down, basically. So the saccule and nutricle are part of the vestibule, that common area of the inner ear, just where the foot of the stapes sits between the cochlea and the semicircular canals. They determine static equilibrium and what's referred to as linear acceleration, like stopping and going in a car or in an elevator, something like that. They detect the pull of gravity on what's referred to as an otolithic membrane, this gel-like membrane that is studded with little otoliths, little crystal-like structures that are almost like rocks that kind of add weight to the membrane. And when the membrane is tilted in one direction or another, gravity will pull on that membrane and cause the stereocilia of those hair cells to bend in one direction or another. So this bending of one direction or another, this allows you to have your eyes closed and you can have your head positioned in any direction, and because of that you can determine which way is up and which way is down. You basically feel the pull of gravity. Or if your eyes were closed and you were in a roller coaster, you could tell when you were being pulled to the left or you're turning to the right, or if you were going up or down. So that is the saccule and utricle of the vestibule. So the semicircular canals, they detect rotational movement and acceleration of the head. And there are three different semicircular canals. If you think of three different planes, think of your basic algebra. You've got X and Y, but you add Z as your kind of third dimension. So you've got this anterior, posterior, and lateral semicircular canals are oriented on basically in these three different planes from each other. They can tell different directions. Again, another kind of extra credit thing will probably be this nystagmus of the eye. Nystagmus refers to a flittering of the eyes back and forth in one direction, but this is a very specific nystagmus reflex that we see in the semicircular canals. So at the base, again, of each semicircular canal, you have a swelling called the cristae ampullaris. In the cristae ampullaris, you have this, again, the gel-like structure here is referred to as a cupula, but it's a very solid but flexible gel-like structure. And again, the stereocilia of the hair cells are embedded within this structure, and movement of the fluid will cause that structure to move in one direction or the other. So again, the hair cells can not only determine rotation of the body, but they can determine direction of rotation of the body, when that rotation starts and when that rotation stops. If you ever spun around and then stopped yourself and then feel your world kind of spinning around back and forth, that is nystagmus that you are experiencing. The flicking back and forth of your eyes to you is very disorienting. But if you were still spinning around, that flicking back and forth of the eyes actually allows your brain to take in little snippets of visual information. Is we don't really watch movies that move. We watch a bunch of stills that are shown to our brain, in a rapid succession. So your brain swings your eyes in one direction, takes kind of a snapshot of information as it swings back, and then swings them in the other direction. The direction that your brain swings your eyes will depend on what semicircular canal is stimulated. You can put your head in one of three different directions or three different orientations and spin yourself around and get your eyes to do three different types of reflexes in response to that nystagmus. So you should know the various diseases and disorders of the eyes and ears that you have on these last four slides. So you have here conjunctivitis, trachoma, neonatal gonorrhea, ophthalmia, and a sty. So you should know these as well as the next few slides. You should know myopia and hyperopia. We talked about those, near and farsightedness. Presbyopia is decrease in near vision, a normal part of aging. We did talk about reduction in accommodation. That's basically presbyopia. Literally, I believe it's old eye. But this is Grandpa, again, reading the newspaper at arm's length instead of closer to his face like he did 20, 30 years ago. So accommodation, the thickening of the lens, decreases. And as a result of that, your near point of vision decreases as well. Astigmatism is a non-uniformity of the eye. Strabismus, again, uh, diplopia, double vision, color blindness. You should kind of know some of these. I'll throw a handful of some of these out as well. Again, cataract, macular degeneration is a very fairly common cause of blindness in this country. Again, we talked about glaucoma as well. Remember the inflow and outflow of aqueous humor. Diabetic retinopathy. Again, the retina is a very highly nervous tissue. Nervous tissue requires a lot of blood, a lot of oxygen, and when you have severe diabetes, one of the first things that happen is those small blood vessels get clotted off. So you run into diabetic retinopathy, and you run into kidney issues with severe diabetes as well. Retinal detachment, again, can come from a blow to the head. You can sometimes see retinal detachment in baseball and softball injuries. So some of the hearing losses. Again, you should know the difference between conductive hearing loss and sensorineural hearing loss. So we talked about movement of sound waves of vibration. So a conductive hearing loss would be somehow not being able to transmit those vibrations from the tympanic membrane to the foot of the stapes, or something along that line is not quite right. So if you can't cause a vibration of the fluid within the inner ear, you're not going to be picking up vibrations from the hair cells. So assuming even the hair cells were working, you can overcome conductive hearing loss with hearing aids and things like that. You can overcome transmission of vibrations. With sensorineural hearing loss, you've got deficiencies of the cells within the spiral organ, like the hair cells, or the stereocilia. Something is either the hair cells are not there, stereocilia not quite working properly, or you might have issues with the nerve pathways. Now, some of this may be treatable depending on exactly what the issue is. If the nervous pathways are intact and it's simply the hair cells, you can do things like cochlear implants, where they can implant electronically and stimulate those nerves electronically along the spiral organ. So you can have maybe hair cells that have malfunctioning cilia, or something like that. But again, the treatability changes or is variable. So you should know some of these. Probably the most common one is tinnitus, the ringing of the ears, and yeah, a very, very typical one. But again, you should know these for the practical as well.